Good. Well, good to end on a non-controversial topic here, so I appreciate that. Especially, so I have a lot of disclosures, but my main disclosure is I work in a hospital, so I'm going to be talking about site of service as a hospital employee. So I'm not sure if anybody remembers any of this, but this was the main document that really changed reimbursement for outpatient ambulatory PVI. So this was a rule in the end of 2007 that changed the payment scheme in 2008. So a pretty dense document, but we can see what happened. These are data from my friend Skylar Jones. And as soon as, the approval came for really reimbursing more robustly outpatient procedures, we saw a large efflux of procedures out to the ambulatory offices. So in the bottom here, that light blue is that general trend towards how ambulatory PVI became really a mainstay of our practices, and a decline in inpatient procedures in particular, but overall growth in the market. And interesting, if you look at the early adoption really and how PVI came about, there was a pretty nice match between vascular surgery and interventional cardiology driving this efflux. So, as mentioned before, the best CLI debate, about 50% of endovascular procedures in the U.S. are performed by vascular surgeons. And so we saw a nice change in trends here. So this wasn't in the title, but the inference was, what about atherectomy? And so I'm just going to head it on the head. And my approach to everything is to try to support with data, and if I can, my own data. So I'm going to show you a little bit of data we've published on this topic in ACLBLs. But there's no doubt that as procedures move to outpatient setting and reimbursement incentivized use of atherectomy grew. And you can just see the proportional use of atherectomy with that general trend of outpatient procedures. So I think that's a fact, and I'll kind of summarize that, and hopefully John agrees with me. But, if you look across the country, there's variation, but pretty much consistency in terms of how atherectomy is used as a general percentage of peripheral vascular interventions performed in an outpatient setting. And if you look at predictors of using atherectomy, time and time again, the strongest predictor is place of service. So I think to answer the main question is, does site of service predict the treatment of choice? And I think in the current reimbursement scheme, the answer is yes. So then it comes to what is the harm of atherectomy and what is the harm of outpatient practices. And this is another paper published not too long ago, and again, really supporting again, and I'll come back to this document in a minute, but really supporting again the ambulatory procedures are one of the largest predictors for using atherectomy. So I had a question a couple years ago. I was kind of playing around with some data, and I said, we don't have a lot of data in ACOBLs, and Medicare is unique because you can find place of service for any Medicare beneficiary. So I can find out wherever you had your procedure and what your outcomes look like. And I didn't know what I was going to find, and I started this project with my what's called a Sarnoff fellow, a cardiology fellow who's at Columbia right now. And I was a little nervous because I was like, I'm not here on either side. I'm here independently, but I was concerned that I was going to see some trends that were biased against outpatient practices. And so we pulled a number of femoral popliteal artery interventions, so 130,000 procedures. And we looked at office-based, so ASCOBLs, about 40,000 procedures versus hospital-based FemPop interventions, 90,000 procedures. What did we find? Well, first to the answer of this debate, that there was more use of atherectomy in the ASCOBLs. So that was an answer that we thought we were going to get, and we found. What we didn't expect was who's being treated in ASCOBLs. And so we looked at race. More minority, more Black patients were treated at ASCOBLs than in hospitals. We looked at socioeconomic status. Patients who are poor, so we define that as being enrolled in Medicaid and Medicare, were more likely treated in ASCOBLs. People who lived in more deprived regions were more likely treated in ASCOBLs. So, the mission of outpatient care, and particularly these freestanding centers, is access and timely access. And so, again, we didn't know what we were going to find, but we found this trend that there are, important access that's being, provided by these centers. When you look at outcomes between office-based here in green and hospital-based in red, even when you adjust for all these risk factors, there's actually a slight favoritism towards office-based practices. Now, again, I don't look at that as you're going to have a longer, healthier life because you get treated in an outpatient center. I look at that as the appropriate patients are being brought to an outpatient center when they are treated in an outpatient center. And so we didn't see any signs of harm associated with these clinical settings. And more importantly, we didn't see them among patients who are the most vulnerable. Again, looking at those who are deprived, looking at those who are of minority race. The interesting thing we also looked at was I found all the providers in there who practice in both an outpatient center and a hospital. So I said, okay, well, let me look at the outcomes for that same provider based on whether they're bringing patients to the outpatient center or the hospital. Same findings, really. There was favoritism for office-based practice, which, again, I think suggests that the appropriate patients are being treated in outpatient settings. So when we talk about what devices you're using and how you're practicing, are they harming patients? These data don't suggest that. And this has been replicated in other studies. It was actually by Enrico Asher and a group looking at another site and overall outcomes, and they had the same conclusion that there's safety in outpatient centers. So is atherectomy harmful? That's the next question. So we're using more atherectomy. The answer to my debate is yes. Is it harmful? Well, we looked at this as well. And we looked at this at a larger level. I didn't look at this as a distal embolization during the procedure or a small perf. We looked at this as, are you going to have more amputations over the long term if you get more atherectomy? We couldn't find a harm signal with atherectomy versus no atherectomy. We found some trends towards less amputation and less surgery, and that's probably local practice patterns and the preference to keep these patients in their clinical place of service. But overall, we didn't find that atherectomy was harmful. If anything, when we looked at across different types of patient populations, we saw consistency in the safety for amputation-free survival with atherectomy use. But, I'm going to end my talk here is OBL-ASCs provide an important service to minorities and other access areas. There's an important complement to what we're doing in our peripheral vascular care. This is a strange moment in vascular practice right now as we've entered a tough year for all of us. And I think it's clear, and this is, again, highlighting that paper I presented earlier, that place of setting does often select the type of procedure that you're going to get, including atherectomy. The problem, again, is that we're dealing in a contentious spot where costs, division in specialties are all dividing our practices. And so I think that the use of atherectomy is greater. The harm is not necessarily there, but we need to police ourselves better. And I think that's probably the most important part of this. And so, for John to debate back, my answer to my own questions is atherectomy used more frequently in ambulatory settings? Yes. Do outpatient outcomes differ by clinical settings? And I put no here. I think that there is safety per this data and other data we've seen with outpatient procedures. Is there clinical long-term harm with associated atherectomy devices? If people are using atherectomy, is there harm? And I don't think there's harm. Now, again, are they always needed? Maybe not. But I'm not sure we're actually doing some detriment to their patient. But should we be more strategic with our use of atherectomy devices? And I would say absolutely. And I think that would be my take home of this debate is, use the right device for a patient. I think we're incentivized by the wrong reasons, and I blame Medicare for that, not any individual practitioner. And again, I'm out of this debate. I work in the hospital, but I think it's a time for us to make sure that we're all on the same page while we take care of our patients. Thank you.